Very good, thank you. I hope we have some enthusiasts in the crowd or those looking to start a program. I'm going to use really the next 15 minutes just to talk about how we got started in renal denervation, what we built to support the program, and hopefully some tips for you if you're interested in getting into this procedural space. These are my disclosures. So, as everybody is aware, this has been a long haul, and we have Dr. Bhatt up here who's been involved in this well before me. We've had negative trials. We've had a series of positive trials. You're going to hear more about that in the next two talks from Dr. Sharp and Dr. Bhatt. But in November 2023, we finally had 2 devices approved in the U.S. for commercialization of renal denervation, Medtronic Spiral, Simplicity Spiral System, and then Recor Medical's Paradise System. So again, you're going to hear more about these in a moment, but overall there's some similar overlaps in terms of the indications for use for treatment of patients with uncontrolled hypertension in the U.S. And to summarize this is kind of blending both of their labels. This got a very broad indication. We actually have an analysis we did, and if you look at the 30+ million U.S. Americans who have uncontrolled hypertension right now, these criteria I'm going to read to you right now apply to about a third of them, so up to 12 million patients would be ready to go for renal denervation today. So renal denervation is indicated to reduce blood pressure and is adjunctive treatment in patients with hypertension whose lifestyle modifications and antihypertensive medications do not adequately control blood pressure. So those words there give you a lot of latitude as a physician and who is appropriate for renal denervation. This is a very early procedure, so I'm going to give you our experience and approach of bringing this to the Beth Israel in Boston. When you look at the vascular and other contraindications for treatment, they're quite broad. Really, you're treating a renal system that's between 3 and 8 millimeters. And in some of the systems, we focus on both our accessory arteries as well as the main arteries. And then the usual anatomical exclusions we would want to avoid, including fibromuscular dysplasia and aneurysm. There's a slightly different considerations for renal artery stenosis. 50% or more you shouldn't treat with the Spiral, 30% or more with the Paradise. But overall, a lot of similarities. And the GFR cutoffs right now is about 40 to 45. We've done a lot of kind of base work as we saw the programs here moving along in terms of approval. SCI, one of the interventional cardiology societies, has a series of documents that kind of helped both determine the patient population that we should be really focusing on, as well as you'll see later in my talk some of the competencies that are necessary for doing this procedure. And please let me know if you have any interest in looking at any of these documents. But you know, the big part here that you're going to see focused on, we talk a lot about this throughout our vascular procedures and conditions, is shared decision making between the physician and the patient. And this is definitely one of those procedures where it's rare you're going to show up to work one day in the cath lab or the OR suite or the procedure lab and have a day worth of patients ready to get renal denervation you've never met or has never been there. So this is really an ongoing relationship, and again requires more than just invasive endovascular specialist, just like what you heard before for wound care. This is probably the most important document that we published in the last year and a half, and this is really what most of our credentialing documents are being based off in our hospitals. Again, this is freely available online. This was led by the Society of Coronary Angiography and Intervention, and it really outlines a little bit on selection criteria, which I'll go through, but also some of the procedural and institutional characteristics you should be thinking about. Again, this is an enriched population, as everybody here is endovascularly trained, but where we talk to a lot of other providers around the U.S., they are not always. And walking through this document, I'm not going to have you look at this figure, but it kind of outlines where you should be investing your assets for building a hypertension and renal denervation program. And the key takeaways right now is, you know, I feel strongly this is not a one-person program, and so not one intervention is going to build renal denervation. We have a lot of buy-in from our non-invasive team, in particular hypertension specialists, and fortunately there's been a movement to grow the presence of these, just like our non-invasive vascular medicine people. Being endocompetent, again, we're enriched for that in this room, and then obviously hospital and administrator buy-in. So this is a little bit of background about our hypertension program. When we put this together, we looked at it just like we look at limb salvage programs. We wanted to make sure that we had a good job of diagnosing, excluding patients who had other conditions that could be treated without renal denervation, making algorithms about how we approach medical therapy, and then layering in our advanced therapies as indicated. And again, when you walk down the hypertension paradigm, this is not something I spend a lot of time in, even in my days now as a cardiologist, but these are the things that we have to think about to find those patients who are going to get the most benefit. Because even in the trials, up to 1/3 of patients did not respond to renal denervation, and you'll see the data is really remarkable for those that do respond, but we want to start to pull out the people that may not have a response to this treatment or have other ways to manage their blood pressure. I just want to highlight for everyone, there are more secondary causes for resistant hypertension that we probably remember or have worked up, and renal vascular disease probably resonates the most with our group, making up anywhere between 5 and 34% of secondary causes of uncontrolled hypertension. But I just want to remind everyone, easy stuff you can do with a partner is ruling out primary aldosteronism, which can be as high as 20% of people with resistant hypertension. These patients will put them on a mineraloid receptor antagonist. We'll try to treat their aldosteronism, but we still have brought them for renal denervation if they don't meet their blood pressure goals. So it's not an exclusion from having the procedure, but it's something that could augment their response to treatment. And then obstructive sleep apnea, as you know, is a very common in the US cause of resistant hypertension, especially with our obesity pandemic. I won't harp on this slide, and again, anybody can access, email me or access these slides afterwards, but this is really our approach for optimizing medical therapy. The real goal is to try to get some component of a diuretic therapy on. We usually still rely, and I'll show you again some of these documents, on 3 or more meds before we start thinking about moving to renal denervation. We're fortunate where we have a pharmacist who helps with our titration protocol, so we have some of this going on in the background, but really important to get people on established antihypertensive therapies, and ideally 3 or more before we're considering them for renal denervation. Well, these are my partners back in Boston. Jennifer Kluwitz, a primary care doctor who specializes in hypertension. Anna Krawitz is my partner. She's a vascular medicine specialist, non-invasive. And they put together this program we call the Complex Hypertension Clinic. This falls within our group. I run a vascular group there. And we really see all the resistant hypertensions in our system. So we have hundreds of patients right now being referred to us. Not everyone meeting the criteria to get to renal denervation, but it's created a real nice pipeline into our institution. And this has become a big part of our growth for our cardiovascular division. So just for this section, and I'll move on to a little bit procedural-based aspects next. As you start planning this out, it's good to get a couple procedures under your belt, but if you want to make this a durable program, identify someone, whether it's a cardiologist, a nephrologist, endocrinologist, primary care doctor who has an interest in hypertension. More and more mid-level nurse practitioners, physician assistants can be involved in this, but it's really hard to do this without also with trying to do the procedural aspect. And then, as I showed, there's really an algorithmic way to whittle out the patients who would most benefit from a procedure like renal denervation. In terms of the procedures requirements, again, enriched room. We spent a lot of time thinking about this because in a lot of the trials that were done, this is primarily embedded in interventional cardiology to start, but there's a big movement to move this into interventional radiology, vascular surgery, and other specialties. I know IR here, including Rob Luxstein, has done renal denervation. And so the goal here is to democratize this. It's not a challenging procedure, but also there can always be a complication and anytime you put a guide in any artery. And so you need to be prepared to have either your capabilities to bail yourself out or have someone on site to. And so to start, if you already have endovascular privileges, right now it's just 5 proctored cases. Usually that's with one of the sponsored devices. We run a program in Boston where you can observe cases in the lab with us, but 5 proctored cases if you already have endovascular privileges. If you don't have endovascular privileges, again, not as pertinent to this room, the goal is to have 10 supervised cases, and they can be active renal denervation cases with a renal angiogram, but again, you need to know how to engage selectively, guide catheters, stents, how to bail yourself out if you have a capsular hematoma. And so there's parts of this that really require you to have a little bit more than just a privilege to do any endovascular treatment. Other things that are really important, you'll see outlined in this document, we use a lot of DSA imaging, again, for this group that's not challenging. One thing that comes up a lot is we do everything under conscious sedation. So I'm an interventional cardiologist, so I'm used to working with primarily our nursing staff, but you really, can cause a pain response with this procedure, which makes it challenging to complete it safely. And so we really aim for deep conscious sedation. We use a lot of IV Benadryl to help with sedation. We use higher levels of our of fentanyl Versed because of the response, but we're able to do this safely, and I'll show you our experience without needing anesthesia or any type of additional sedation or airway protection. But again, as an endovascular specialist here, you got to have familiarity with the aorta renal anatomy, multiple guides. I mean, we do this with IMAs, we do this with renal double curves, support and non-support wires, and as I mentioned, stents, glues, and coil. This is our document right now. So we have a specific document for renal artery denervation that is following that SCI criteria. If anybody has any interest in this, please let me know. But it kind of highlights what was laid out in that document. And again, the highlight here is to being an endovascular specialist with some sort of renal artery experience. It's not anything aligned with a specific specialty. So again, you can do this as an interventional radiologist or vascular surgeon as well, but it's meant to be endovascular privilege. Let me just speak a minute on patient selection, and then I'm going to show you some of our local data. So, if you look at the benefit of renal denervation versus medical therapy right now, obviously we can get really effective medical therapies to our patients. So we call the efficacy roughly equivalent. But tolerability, again, we've done renal denervation, and patients are there for about 2 hours. They go home after an hour or two of observation, and that's their treatment for years to come. So tolerability has been quite favorable. We haven't had a lot of off-target side effects. Safety has overall been very favorable for renal denervation. We have a lot of patients who feel, whether it's true or not, that they have side effect issues with their antihypertensive regimens. We're getting more on durability. We've seen data now out through 10 years through European experience favoring renal denervation. And probably the most important thing here is adherence. We know that up to a third of patients who have hypertension are not adherent with their daily medication regimen, and so having an always-on therapy is quite beneficial. We talked a little about shared decision-making. This is in one of our documents. But really, the one goal I wanted to put in this slide is that what patients want are not always aligned with what physicians want. And I think we have to remind ourselves, we're responding to the numbers. We're thinking of our quality. We want to treat people who are uncontrolled to get our blood pressure overall numbers in range. Whereas patients are thinking more about side effect profiles and experience. What is it like to have a procedure? What is it like to take medications up to 5 a day? And so aligning those are really critical for moving forward with considering an invasive procedure for hypertension. We kind of lay out in the document 3 criteria that kind of fit within the FDA guidelines. Now, this preceded the guideline IFU, but really looking at resistant hypertension, defined as being on 3 or more meds and a blood pressure that's over 130/80. Patients who might be intolerant to meds and remain uncontrolled, and we treat less of those. That's a population I'm a little bit more guarded on their response, but the 1 or 2 med person who just can't take it every day or has tried every med and they still have a complication. And then really emphasizing those who have a higher cardiovascular risk. We know that uncontrolled hypertension is a major driver of stroke, heart failure, myocardial infarction, cardiovascular death, and so those that are already enriched for these events should be prioritized for treatment. Just a comment, I have in parallel, our group is seeing these patients continuously, and we're seeing about 30, 40 patients referred for renal denervation a month. And I'll tell you, these are a series of conversations. There are some patients who are sent over by their proceduralist to say, I want you to have a procedure. That conversation is different than the person who gets sent over and said, you have uncontrolled hypertension, we're going to find a way to control it. And so, usually there's some relationship building with their physician, and this could take 4 to 5 visits before they're ready for a procedure. So you got to, again, have the right infrastructure and expectations when building this program. And I'll just highlight again here that shared decision-making is key. So we've had a program now in place. We started, I think both of these devices are phenomenal, and we have every intention to have both of them in our system. We had Medtronic come in first just from a VAC committee standpoint, but we were in their trial, so it was a natural lead-in. So we did our first case as part of the AFFIRM study, which was a pre-registry study, not post. We've done, I think now over 20 cases. We have here 17 cases to date, both commercial, and then also we have the clinical experience. And I just want to highlight, many of our patients coming in are on these type of regimens. So they're on clonidine, they're on doxazosin, they're on old school meds like minoxidil. So these are, again, we're not cherry picking patients who just don't feel like taking their meds. These are patients who are struggling on really complicated regimens, are on 3 or more meds, are remaining resistant. All our procedures come in, they go out the same day. So we've done more than 20 cases. All cases have been less than 90 minutes. We've had no procedural complications. We've done everything with conscious sedation, and everybody's been discharged home the same day. We follow patients in a very algorithmic way post-procedure, and again, I'm happy to share this with people. Funny enough, this has not been laid out. When you bring in a new therapy to market, we're all kind of trying to figure out how to create a post-procedure protocol. And so we've been seeing them kind of 3, 6, 12 months. Again, we see them, sometimes we'll send them back to their referring doctors and we'll just do that first period of follow-up, but really looking at their blood pressure or post-procedure labs. There's more and more data showing that GFR, renal function, actually stabilizes after renal denervation compared to age-related decline. So it's really nice to see some other aspects of this treatment manifesting in your post-procedure follow-up. We also started at the Beth Israel at our research center called the Smith Center, a registry. We have a dozen sites now who will be submitting data of all their commercial cases in the US. If anybody is interested in joining this is free and available to anyone. So today we have, again, November was when the approval came. These are all commercial subjects. We've done 20 plus commercials. 8 patients now are in that 6-month time point. I just want to highlight, we do 3 measurements in the office. So we do an office systolic blood pressure. We do 2 ambulatory or automated office blood pressure, so that 5-minute protocol that was used in the SPRINT trial, and then we get home blood pressures from the patients. But you can see overall, we've had a very nice response to our renal denervation. We've got an average on the 8 subjects, 24/10 blood pressure reduction. It's always a little bit more attenuated with the automated blood pressure cuff, so 16/9 there. But we still, again, see some of that variability in response, with more than half having at least a 5 to 10 point drop, but some people having much smaller amount of drop. That's all I have for you today. If anybody has any interest in these slides, or if you're interested in setting up a program, this is my email. I'm happy to send them over, including credentialing documents. And there's always questions about prior auth and reimbursement, which is not the right conversation for right now, but definitely something to consider as you kick off your program. Thank you very much.